Good morning, one and all. Warm welcome to the first session of the day. We welcome you all to Hall A. The first session today to start with is the most interesting topic, that is traumatic elbow instability. So hereby I request my colleague Dr. Ravi to introduce the conveners, and I please call them on stage, Dr. Shakir Kapadia and Dr. Santosh Patil, please.
Good morning, everybody. It's always a pleasure come back to WIROC, and it feels like coming back to home. So we got Dr. Santosh Patil. Santosh is an postgraduate from Cheyenne, and he is the head of orthopedics at Rajawadi Hospital. So here, Santosh.
We call upon Santosh to give a small brief about the topic, and then we go forward.
The panelists as well.
Okay. We call the panelists, please. Can we have on stage Dr. Manoj Pahukar, Dr. Asim Negi, Dr. Parag Shah, and Dr. Shailesh Pai.
Panelists, take the stage, please. Thank you. Next panelist again, we've got Dr. Parag Shah. Welcome, sir. Dr. Parag Shah is a consultant shoulder and upper limb surgeon, and he's got his own setup at Ahmedabad, practicing with complex trauma surgery. We got Dr. Manoj Pahukar. Dr. Manoj Pahukar is a senior orthopedic consultant at Alexis Hospital in Nagpur. He works at the Young Surgeon Forum at YSF Orthopedics. He's got affiliation with VOS Secretariat and organized MAOCON, POSICON, WOSCON, and many more conferences. He's a national faculty, and he's got AOTAP Hong Kong podium presentations as well. The last panelist is Dr. Shailesh Pai. Morning. Dr. Pai is a consultant trauma and pelvic facetable surgeon at Tejas Canyon Hospital, Mangalore. So welcome you all to this very interesting session on the complex elbow instability.
So to discuss and start the session, first call upon Dr. Santosh Patil. He will be discussing in brief about the topic, in discussing the important aspects of pathoanatomy, the surgical treatment of this terrible injury.
Thank you, sir. Good morning, everyone. I am Dr. Santosh Patil. I welcome you all to WIROC MAX 2022. Over next 45 minutes, we will be discussing on one of the important injuries in trauma, that is traumatic elbow instability. Elbow joint is an inherently stable joint which is fortressed by primary stabilizers, osseous and ligamentous articulation. Main stabilizers being in primary category ulnohumeral articulation, anterior band of medial collateral ligament, and lateral ulnar collateral ligament, which is equally supported by dynamic secondary stabilizers. Whenever traumatic forces overcome this fortress, then dislocation happens. Elbow joint is the second most commonly dislocated joint. Usual scenario is fall on outstretched hand, and whatever we do in the initial management, like close reduction and instability assessment, it has a bearing on the outcome. Usually it is a continuum of injury. It is subluxation. It ranges from subluxation to simple dislocation without any osseous injuries to complex dislocation where fractures can be seen along with this ligamentous injury. And there are different patterns like posterolateral rotatory instability, which is the most common, and different other patterns we'll be discussing in case-based discussion today. Now coming to one case, just to discuss and highlight the importance of simple elbow dislocation. This is the lady presented to casualty, 45-year-old lady with fall on outstretched hand, and treating surgeon has reduced it and put her in slab. He found this is completely okay, and he asked the patient to follow up after 3 weeks. After 3 weeks, he got the X-ray done, and again he found everything okay, and he asked her to do physiotherapy. And at 10 weeks, she presented with painful restriction of the movement. So this is an unstable, painful joint. So what has gone wrong? How to assess the instability? Are all simple elbow dislocations benign? How to predict instability after a simple elbow dislocation, close management, and what is the role of CT and MRI? I would like to ask question to our panelist. Dr. Parag Shah, would you like to take this? How will you assess instability after close reduction of a simple elbow dislocation?
Thank you for this talk here, and it's a very interesting case. And sometimes simple elbow dislocations are not so simple. A lot of times we assess them only on a lateral X-ray, but I think the anteroposterior X-ray is extremely important to know whether it is the standard posterolateral dislocation or it is something else. So if you have a situation where you find residual instability, most of the times it is something more other than just a standard posterolateral dislocation. I normally do not reduce them without anesthesia. I take all my dislocations in the OR under deep sedation, under fluoroscopy, to assess the arc of stability.
Yes.
And also the mediolateral instability at that time. If the patient is stable throughout, then I think we are winning here. However, if the patient is unstable in extension, then you can try reducing it in pronation and seeing how stable it does.
Yeah.
And then subsequently we take it forward. Posteromedial dislocations are unusual, but they are the ones that tend to go for significant instability in the post reduction period. So I think that's the red flag that I would like to raise here, that all dislocations are not posterolateral. Some of them are posteromedial as well. Very rarely you have a pure medial dislocation, but those are extremely rare. But I think the posteromedial dislocation is not as unusual as one may think it is.
Yeah, Dr. Asim.
Good quality X-rays, AP and lateral, they are extremely important. If there is a small flack of bone, that signifies that tip of the coronoid along with the capsule has avulsed. So, plus, usually is done by the junior most person, so they should be taught to document arc of stability.
Yeah.
When it tends to redislocate.
Yeah.
That's a very vital information.
Yeah. Sir, what is the role of MRI in acute setup?
So in the acute setting, if there is a case of simple elbow dislocation, it is getting reduced very well. There is no instability. We don't need to go any further investigation. But if you feel that it is unstable, there is some problem, it is getting dislocated either in extension or flexion, then certainly there is a role that there has to be some kind of ligamentous instability or some avulsion injuries of these various things which needs to be identified. Certainly in those cases you should go proceed with the CT scan, and even if needed an MRI could be done.
Yes, fair enough. So our management goals of treatment are getting a concentric reduction and maintaining that during early mobilization and prevention of chronic stability and prevention of stiffness. So there is a study by Mark et al., a retrospective study, and they have assessed all these simple elbow dislocations which were reduced in close manner, and they have advised few tricks to predict instability. First and foremost, as Dr. Parag Shah said, that it has to be, once an elbow is reduced, it has to be run through complete range of motion, and if it is getting dislocated in the terminal extension as well, it is a completely unstable elbow. Get good X-rays as suggested by Dr. Asim Negi, a good AP and good lateral X-rays, and you should look for joint incongruence and drop sign. Increase in the joint space by more than 4 millimeter is classically called as a drop sign. So all these things on X-ray do indicate instability. Also, these authors have advocated examination under fluoroscopy, as rightly said by Dr. Parag Shah. Elbow is evaluated for stability in full extension and 30 degree of flexion. Varus and valgus stresses are given. And if joint is opening by more than 10 degree, they have labeled these are grade 2 or moderate laxity. Obviously, grade 1 laxities are going to do well with conservative management, and grade 3 requires dysausi. So in 2017, they came up with these recommendations. Grade 1 laxity, they can be managed with a conservative management with functional rehabilitation as early as possible to prevent prevent stiffness. Grade 3 laxity, definitely it goes for primary ligament repair to get the stability. Grade 2 laxity comes in a gray zone. You need to investigate it further with an MRI or maybe more other investigations to come to a conclusion. So whenever you are planning to contemplate a surgery, your goal is always to downgrade the injury, bringing pressure down this step ladder. This is a ladder shown for most common posterolateral injury. We'll be starting with on the lateral side, which are the most unstable structures. We'll be repairing lateral ligament and common extensor origins, and then we'll be reassessing it intraoperatively. If there is still an instability, we'll be going on the medial side and repairing the medial structures as well. So recently, there are many studies who have published that there are good results with primary ligament repair in most unstable cases. So with this brief background, we'll be starting case-based discussion. May I invite Dr. Asim Negi, sir, to have a first case.
Friends, good morning. This 72-year-old female who was on BiPAP and oxygen at home for last 10 years had a fall at home and sustained this injury to elbow. I don't think any one of us will treat her conservatively, but she was denied surgery by 2 orthopedic surgeons due to medical reasons. This was a costly act of omission for this old lady. Given a plaster for 8 weeks, 3 months X-ray almost looks the same as the 2 months X-ray. She has got pain, instability. She can't do activities of daily living. That's the stage she came to me. I got a CT scan done. You can see a flake of bone marked by the arrow. That denotes the tip of the coronoid where capsule got detached. Joint is subluxed and head radius is lost somewhere in the soft tissues far away. Elbow is one joint where 3D images are more informative than conventional wisdom of 2D images. We can operate these patients. Obviously, she required surgery. We can operate them in the supine position on a side table, which we did in this case. Some people prefer to operate in the lateral position as shown. But of late, for doing surgery around elbow, we have found this new setup very convenient. If I keep the hand on the side table, I can operate the front, sides. I can image the elbow very easily, and if I want to operate on the back side of the elbow, I just flex the elbow and can go on the back side, or I can do things on the ulnar. So it's a very good position to give. We can do it by combined posterior and lateral incision or a conventional Boyart's approach, but we did it with a trans-olecranon approach. That is the article. It's something like an extended olecranon osteotomy. Gives a beautiful view of the proximal end of the radius for arthroplasty or fixation. And you can as well take the capsular stitches in the coronoid through the same exposure. So trans-olecranon approach, head radius had to be retrieved from posterior soft tissue with the help of image intensifier. Correct size of the head radius was selected and a trial head inserted. In this case, my trial head was radiolucent, so the artery is showing the top of that prosthesis, which is at the level of tip of the coronoid. If in this case the tip of the coronoid was with the distal fragment, if this area of ulna is comminuted, then you will have to do a temporary reconstruction of proximal ulna with KYS, then only you can do the correct trial reduction. These are the tips for a good radial head arthroplasty. Don't overstuff like the picture shown on the left side. In the lateral view, top of the prosthesis at the tip of the coronoid. On AP view, it should be at the level of sigmoid notch of ulna. There should not be any opening up of the joint space on the lateral side, and you should move the joint through the arc to look for stability. If you are in between sizes for the head radius, if in doubt, choose the smaller one, and then the olecranon was reduced, fixed with tension band. This was done almost 4 or 5 years back when I had access only to monoblock, loose fit, short stem prosthesis. I would like to know from my fellow panelists what's their choice for the head radius prosthesis today when options are available. She was 72, 3 months old, fracture, osteopenic, so we added a neutralization plate and then checked the stability in flexion and extension. Plaster was there only for 10 days, and then the exercises started with the help of a hinged brace. Wet lifting restrictions were there for about 3 to 4 months. That's her 1 year follow-up. That's her clinical picture, and that is her function at the end of 3 months or 4 months, and she maintained this function till the end. She has got a full pronosupination. She can do all her activities of household work. She's fairly independent. So my take-home message is, for a complex fracture dislocation of elbow, in these situations, fix the coronoid and anterior capsule, restore articular congruity by reconstructing the trochlea meticulously. Anatomic reconstruction of the ulna is key to restore stability to the joint. Remember that ulna is not a straight bone. Use of 2.4, yes, 2.4 millimeter locking plates are now available, or a 3.51 pre-conduit plate. You can combine tension band with plating for comminuted and osteoporotic fractures. At times, if there is severe comminution and my hold with the metal is tenuous, then I take 5 number fiber wire and make a craco stitch in the triceps and tie it to one of the holes of the plate. Then you repair the or replace the radial head. Please do not excise it. Repair the lateral collateral ligament complex, especially the LUCL, and then you evaluate stability. If joint is stable up to 30 degree of flexion, you may not do the medial side. But if it's unstable even at 30 degree of flexion, then you should repair the medial side also. Aim to achieve a stable joint on table, which allow you early motion in the post-op period, and a hinged brace is extremely useful. I don't have any experience of using external fixator or recently introduced internal fixators which are available abroad. I don't have any first-hand experience. Now I would like to ask my fellow panelists, in the terrible triad injury, if you don't have access to radial head prosthesis or you have not kept it, what do you do, sir? Shailesh? Any alternative?
So the thinking is you fix it in the best possible situation. We can even take it out on the table, fix it and put it back. What we need to see is that we achieve the length so that the ligaments heal around that. So it doesn't matter. It might go on to avascular necrosis. We can do a secondary excision later on, but do not do a primary excision.
There is a 2018 article which compared 20 cases with replacement and 15 cases with only MCL and medial capsule repair, and the results were equivalent. Our Dr. Tanna also has got about 8 or 10 cases like that, and the results were equally good. Joint became stable. This article talks about 3D printed molds for making a head radius prosthesis with cement. But if you are really in a soup and stuck up, take a simple K-wire and ask for bone cement and make your own head radius as a spacer on table, and it will serve the purpose. Actually, this paper tells us that there is least stress shielding with cement spacer compared with PEEK or metal prosthesis. So it's not such a bad thing, and if required, you can always take it out later on when joint has become stable.
Asim,
Ji, sir.
one simple question. How important it is to replace the radial head in today's 2022 scenario?
Very important. Replace or repair. Whatever is possible, we all know that more than 3 pieces nobody will. Or if there is severe crushing, nobody will. The next question is the same. Have you done a head radius excision in last 5 years, any one of us? Have you done, sir? Shakir bhai?
I do it even now.
In complex fracture dislocation?
Oh, in a simple this thing.
In a simple, everybody. Parag sir?
Yeah.
Hello.
Very rarely in chronic cases with either with massive heterotrophic ossification or a direct involvement of the radial head as a part of malunion or something, I would do that.
Those are stable situations.
Yes.
Manoj sir?
Yeah, I do have very low threshold for going for the replacement, because the malunited or not properly reduced radial heads or these neck fractures will give you more trouble than replacing it. This is just a spacer. So always try to be more on this side. If it is not reconstructable more than 3 fragments, there is a radial neck which is comminuted, not good instability. Even if you are fixing the coronoid, if these all 3 things are there, always I will go for radial head replacement in such scenarios.
Sir, what do you use as a replacement? What is your preferred thing? In a financially constrained situations, we are not talking about...
So when you have these complex fracture dislocations and when you want to restore your lateral column, I use the biotech radial head replacement. I think amongst all the ones which is available so far, it's a good system, it's uncemented, and it has multiple sizes and some degree of modularity, and not very expensive. It's about 24-25K.
That's great, yeah. So, you can excise the head radius only when the ligaments are intact. You can go for excision, but a review of literature tells us that more often than not, they are not intact. Series tells us 75%, 88%, 100% ligaments are not intact. And this is the latest article in 2020, where they have compared a radial head replacement versus resection in complex elbow dislocation. And you can see there that functional results are far superior with replacement. Resection leads to a lot of disability. Resection group also had a higher rate of re-interventions and HO formations. So be careful when you are choosing resection. You should be very sure that ligaments are intact and joint is stable and it will stay stable. And one more thing about the resection, even in those situations where joint is stable, it disturbs the weight bearing axis of the forearm. So down the almost 10 years after that, there were forces which were transmitted from hand to shoulder. They were 9 times distorted. So there is a lot of arthritis. They may not have many symptoms, but radiologically the joint undergoes arthritic changes if you exercise the head radius. So it shouldn't be your preferred treatment, barring very exceptional cases. Thank you very much.
Thank you, sir. One more question I want to ask panelists. What would be your choice in a radial head replacement? What would be the implant design? Press fit, loose fit?
He said he will use a biotech. Parag sir, what's your? Parag sir, Manoj sir and Shailesh.
I'm almost a compulsive radial head replacer by and large, especially because I get most complex situations. So currently, there are two schools of thought. One is going for the uncemented coated stems, which has a very sturdy fit into the proximal radius. We've designed the biotech radial heads, and now I've modified them, and now we have the longer stem. I think globally it is now accepted that you need a slightly longer stem to prevent the certain zones of loosening that happen eventually. But in terms of preference, my first sort of disclaimer is I use it as a spacer. So you can't really compare it to a hip or a knee or a shoulder for that matter. It has a limited use, in terms of providing immediate stability in a grossly unstable situation. You want early range of motion, and you want to maintain the length of the lateral column so that everything heals in as anatomic position as possible. So my choice currently is still the newer long stem monoblock radial heads. Monoblocks.
And suppose you have to take it out because of one reason or other. So
that's why I don't cement them. No, I don't cement them. I never cement a radial head prosthesis. So eventually it can be a slightly loose fit, but always uncemented.
One Indian company has made modular, non-cemented, tight fit type of thing. So will it suffice if we remove just the cap, if it has to be?
I think at the end of the day, if it has to come out, that's what you can do. I am expecting a patient from Central Europe. He's come and shown me, he's an Indian expat. He's got an overstuffed joint, but he's got this coated radial head. And I don't think you can get that out. It's going to shatter your proximal radius.
The Indian one, they have got a screw there. So you can take out the top.
No. So every modular will have a screw, basically.
Yeah. So,
but the thing is that
can we start the second
take
topic
your case
and
now?
Continue with the questions later on?
Okay.
So hereby we call Dr. Parag Shah, please, for his topic on chronic elbow dislocation in a young patient. The talk will be for 5 minutes.
Thank you very much. Morning. Thank you very much to the organizers for this invitation. Thank you, Mr. Chairman and the co-chair and the panel. So, what are the learning objectives from this situation? Although my talk or the case is on chronic elbow dislocation, I think the learning objective is always to prevent that situation. So, I think the first and foremost thing is to identify correctly the elements of the injury. Whether you need a CT for that, whether you need multiple x-rays, go ahead and do that, but identify every component. Treat each element as best as possible. A general rule should be that if you have a presence of a coronoid fracture and a radial head fracture, usually implies that there is significant instability. And 99% of your times, your solution is inside the box. You don't really need to think about other things if you just treat each element correctly. So what are the acute bony instability patterns? One is, as Santosh said, just a plain and simple elbow dislocation. The other one is the terrible triad. You have the adult Montagias, then the Montagia fracture dislocations, and you have the Trans-olecranon fracture dislocation. Very recently, I was communicating with David Ring, and he says that you must think about a transitional lesion, which means that there is a component of each of them there you can have a montagia with an elbow dislocation, you can have a terrible triad with a distal ulnar fracture, and so on and so forth. So you must identify these lesions and treat them individually. So a case in point, this is an adult montagia, comminuted proximal ulnar fracture, a radial head fracture, poorly taken x-rays, no further CT scans really done, primarily treated with an olecranon plate and excision of the radial head. There was a coronoid fragment which unfortunately was not addressed, and it doesn't take too long for this elbow to dislocate. Whether you have a pin in situ, whether you have a plaster, these fractures, dislocations will redislocate if you do not address every element that has been involved. So this is how we received another patient. The previous x-rays are lost, but this was a young lad, 25 something, laborer, had an adult montagia, the radial head excised, the coronoid not fixed, and you have just an olecranon plate in situ with the elbow dislocated. So at 6 months, this is a very difficult situation. He has a elbow fixed at about 85 degrees. He has no flexion, no further motion, prevented restriction, rotations as well. So this was his clinical picture. This is how his elbow was. So the options one may have is obviously operative. There's nothing you can achieve by not doing something for this patient. So you have an open reduction. Do you replace the radial head at 6 months? Do you repair? You're not going to have any ligaments to repair. Everything is gone now. So do you do an acute ligament reconstruction? If you do that, do you protect it with an external fixation, whether it is static or dynamic, or whether you do something else? So there are a lot of questions that are unanswered in a 6-month-old dislocation like that. But there is another option, which is what we've done. And at times, 99% you do not need, but 1% of the times you may think outside the box because somebody else already did that. So this is what was done, and we'll show you how it was done. So this is an internal joint stabilizer as described by Jorge Orbe from Miami. And in its simplest form, this is actually the implant that I have in my hand. This is an ST pin, which is bent in a figure of 8 at the bottom end of it, and then bent on table to fit the anatomy of the elbow joint. The radial head obviously has been replaced, and the coronoid was fixed. Even at this late stage, the coronoid was still there with the attached capsule, and this is what was done. So the proof of concept, this was published by Dr. Orbe in 2014 with preliminary results of using an ST pin as an internal fixator. So whatever your approach, whether it's your posterior approach or your lateral approach, you take this ST pin, you can bend it, you can pre-bend it or even do it on table in such a way that you get a figure of 8 which goes on the dorsal aspect of your ulna and which are then stabilized with 2 3.5 millimeter bicortical screws. Very simple, nothing very fancy. But the horizontal part of it goes into the axis of rotation, which is in the center of the capitulum. And this is how you do that. You drill through the capitellum for introducing this particular pin. And at the end of it, once you have it, this works as an internal fixator on which you can allow early range of motion. So this is what was done. The previous plate was removed with a posterior triceps splitting approach. The elbow was reduced. The coronoid was fixed with a transosseous suture. You can't see, but there is a button out there. This is the monoblock, relatively long stem radial head prosthesis that I was talking about. This is an acute situation, but I just wanted to highlight that you can get to the coronoid piece here. As you can see, the olecranon is fractured. It's been moved out of the way. And this is the coronoid with its attached capsule. And you can do that. You can take your sutures. You can't fix this tip, but you can do a suture fixation through transosseous tunnel and tie it on an endo button on the dorsal aspect of the ulna. And this is him at 6 months post-surgery and is back to his work. And that's his video. He's now completely painless. He used to do a labor work and has a range of motion from about 40 to 110. So it's not a gold medal, but a silver or a bronze works in a situation like this. So now, eventually, after the proof of concept, this is A commercially available skeletal dynamics internal fixator not yet available in India, but it has all the components which have been designed after the proof of concept by an ST pin. Normally, this can be removed at 3 to 6 months, but this patient hasn't come back for removal. It's almost a year. He's in follow-up, but doesn't want a second surgery at this stage. So my take-home message is a complex chronic elbow instability is a very difficult condition to treat. The internal joint stabilizer has a proof of concept and can be used in chronic as well as certain acute cases with severe instability. It's a very low cost method of treatment, especially suitable for a lot of our patients who come at a very late time in presentation. But the main thing is to identify the elements in an acute setting and get it right the first time. Thank you very much.
Thank you, sir. Sir, do you repair ligaments as well, or do you recommend any augmentation of the ligaments?
So at 6 months, there's nothing much to repair. Everything is just a scar. Had I not done this kind of a fixator, then I would probably have done either a palmaris longus or a hamstring with a box repair. So you do a medial as well as a lateral repair. But the point is that you can't mobilize them immediately. Then you probably have to have this dynamic hinge kind of fixators, which are very costly and very cumbersome to apply, as well as for the patient to tolerate that. So if I did not have this, or if I had not used this, it was something that I would do. And then protect it with a static fixator. But then again, you have a problem with stiffness.
What's your mobilization protocol after?
So after this, in this case, just about suture removal, we started with early active range of motion. So we do what is called the overhead elbow protocol. So basically the patient is supine, the shoulder is taken to forward elevation, and under gravity, you start doing flexion.
Thanks, Parag. Thanks for such an insightful talk. Could I invite the next speaker on the
Thank
stage,
you.
please? Thanks. Trans-olecranon complex elbow dislocation by Dr. Pahukar. Thank you.
So very good morning to all of you. So after these two interesting cases, I will be shifting your focus on another kind of elbow instability. It is the trans-olecranon fracture dislocations. This is a young gentleman. We presented with this close injury after a very high velocity accident. And obviously you can see that on radiology, there is a segmental fracture in the ulna, and you also make out there is an unstable elbow injury simultaneously. So on further evaluation, you can certainly find out this is an intra-articular proximal elbow fracture dislocation with an associated ulnar shaft fracture as well. You need to identify the distal joint as well, identify the tomography, and very essential to have a 3D CT along with a 2D CT as well, so as to understand the complex pattern of this injury. You need to identify individual components like the ulnar shaft fracture. You can obviously make out this is a volar or anterior kind of elbow dislocation in this 3D. You can certainly make out this occurring to the trans-olecranon region. And you can make out that coronoid looks to be intact in most of the plane except some comminution this anteromedially. You can also make out on 3D that the proximal radioulnar joint is still maintained. You can make out the olecranon fracture is there with more comminution on the medial side. And this is very important view where you can see that medially there is comminution, as well as if you can make out there is anteromedial or the sublime tubercle which is also fractured and comminuted on this C. So very important to such kind of 3D pattern to understand this uncommon combined pattern of injury which is likely to be underdiagnosed. So the classically trans-olecranon fractures, the entire forearm is dislocated or subluxated anteriorly. The radial head and usually the proximal radioulnar joint always remain intact. The collaterals usually they remain intact. They should always be sometimes confused with the anterior Montegia kind of fracture dislocation, where we know that the key difference is like the radioulnar proximal dissociation will happen in Montegia, which is not there in trans-olecranon, and the key for this Montegia will be the anatomical reduction of proximal ulna. But for trans-olecranon fracture, it is the opposite. It's like you need to restore the greater sigmoid notch or the trochlear notch of the ulna by correct alignment of the coronoid and the olecranon, and then you can assess the instability and repair the other things. So this is the recent classification. Actually, Dr. Parag Shah was also telling this is a Mayo classification where it could be combined kind of. These are all complex injury. You cannot have a good classification. It could be trans-olecranon fracture along with Montegia variant, which could be present in such kind of situation. He described that coronoid is that fragment will decide the further line of treatment. So the timing as early as possible, supine position after Dr. Negi has said they're very essential. Yeah, I use the direct posterior approach where you can simultaneously address both the olecranon and distal ulna. The sequence of fixation, try to see whether coronary is fracture or not. Then go for the olecranon reconstruction. Then you can get the shaft reconstruction. Then see for radial head, and then finally you can see for the instability. So here this is exposed. You can see that I reduce this shaft initially, get a good reduction of the shaft fracture, and you can show this through this trans-olecranon approach itself that radial head has maintained its position. The annular ligaments are intact. Medially, you can certainly make out there is a combination which is present at this region. You need to do this fluoroscopy as well intraoperatively, see assess whether you get a good reduction as well as mediolateral instability which could be happening in this place. So we are able to get that coronary was intact, the radial head could be reconstructed. Then you go for the further evaluation in this injury in the olecranon region. You need to reconstruct this olecranon osteochondral fragments. You need to identify medially if you can make out this anteromedial, this coronary which is there. And you need to see this kind of fluoroscopy again to see that there is certainly lateral subluxation of all of this proximal radial which is happening. So you need to reconstruct medially as well. Very important to identify this sublime tubercle or others fragment. You need to identify the bed where you wanted to go for this repair medial combination of this medial collateral ligament which is attached to this. Identify these structures individually. Then you can reconstruct the olecranon first, get whatever the combination to the position as well as possible, and then go for this sublime tubercle or this coronary fixation. I use the two suture anchors over here, 3.4, 5.5 titanium anchors, which will then engulf with this medial collateral ligament along with this comminuted fragment along with this sublime tubercle. You can see a very good reduction could be achieved in this place. Then you can go for the reconstruction of the shaft fracture. I use the two plates distally so as to get a good stability. Otherwise, this proximal, this wall of this plate was not spanning completely. I will provisionally fix it to the two KYs, this olecranon, and then this buttress whole of this with this anatomical posterior ulnar plate posteriorly. And you can see that we can certainly get a good reduction of the articular as well as this distally. This plate firmly held against and it reduces this comminuted proximal ulna very well. So this is how it will look then after the fixation, these are the suture anchors fiber wires, and then you can assess the stability intraoperatively itself, that it's a very good stable, it is not dislocating, and it's maintaining the contour. Also, always try to see the radial head with the capitulum alignment. Always see for the forearm rotation, able to get a good, there is no ulnar malalignment. Always see there is cremitation if you are any errant screws or anything which is inside. So this is the final X-ray of the same patient, able to get a good anatomical rigid fixation of this shaft as well as a good congruent reduction of this trochlear notch with whatever possible ways with these anchors and these KY, these small fragments which are also could be satisfactorily reduced. Always assess your this reduction congruency of this whole of trochlear notch, where whole of this fulcrum is dependent for the all the further range of elbow movements. Distally also take these views so as to assess the any problem which is happening. So this is the whole AP view of the elbow with the forearm, where you can say there is certainly a good adequate this reduction of this whole of this fragment which could be done. So this patient with good stabilization, I started immediately ambulating, mobilizing this patient in the elbow dial brace immediately. This I had done only from the third or fourth day. Then you can certainly process with this further. So this is just a 3 or 4 weeks back I have done this case. We should always try to see for these patients in the further follow-up the chances of developing post-traumatic arthritis, especially if they are more associated with other coronary fractures, other radial fractures are more common. Luckily, this patient will doesn't have got those associated injury. Chances of this arthritis will be very less. Always try to reconstruct the trochlear notch with whatever possible way. Always try to get that congruity, even if you sometimes need the structural got get it there. Chances of heterotoxic ossification are always there. So my take-home message for this case is like for these all complex elbow instability pressure, especially the trans-olecranon fracture, you need to identify the individual components. May not particularly go into particular classification depending on individual fractures. Like with the radial head, go for Mason; for coronary, go for discal. You can go for that Mayo classification which I explained. So in trans-olecranon fracture, the greater sigmoid node reconstruction is the key. Ligament injury, always you should suspect, then assess it. Usually because these complex patterns are not reliable with the classification system which we know at the moment. Thank you very much.
Excellent talk, and we indeed understand this is a complex problem. The only tip probably I would suggest when there is a coronary fragment is not to try getting the lag screw, if you are putting a lag screw for the coronary fragment, through the plate. try and get it separately and then put the plate on that. And then within Trans-olecranon, you've got a window present already. So try and get your corona reduced. And the key component is to stabilize, to mobilize. We got a couple of questions. Anybody from the panelists? Fine. So we'll move to the last case of this session. Could I invite Dr. Pai? Thank you.
Thank you, sir. Very good morning. So I'll be speaking about a pediatric elbow case which presented to us. A 12-year-old boy was brought by his father with complaints that he is chewing his little finger since about a week. The history was that he had a fall about 3 weeks back, and it was reduced elsewhere. A slab was given and slab was removed a week back, and after that the father noticed that he is chewing his little finger. He was specifically told not to massage that and mobilize his elbow. That was what he was told. So on examination, we could feel there is some emptiness at the place where radial head is supposed to be there. And of course, he had a ulnar no palsy with some clawing. That's his clinical pictures at presentation. As we can notice, there is this emptiness and clawing. His range of movements, elbow flexion was minus 20, and he could get up to minus 20. So he had lost 20 degrees of flexion extension, but it was locked. It was not able to pronate and supinate. And this was his radiograph on presentation. As we could see that the radial head is dislocated. On the lateral view, what we initially thought is some signs of heterotopic ossification is actually anterior longitudinal, annular ligament ossification. So these are these pictures from initial trauma. It was an elbow dislocation which was reduced. And this is his immediate post-reduction X-ray that was taken, and what was missed was that the radial head was dislocated. So this was at 3 weeks after the injury. Current radiograph on the left, and we got a contralateral elbow to have a look what's happening. So this injury is actually pretty rare. We went through the literature to know what has to be done. So we went through a Kaplan's approach. The radial head, like presumed, was missing from where it is supposed to be there. So it's not articulating with the capitulum, it was empty. And ulnohumeral articulation was intact. Then we took a medial incision, and we could see that the ulnar nerve was compressed. There was radial head just next to the ulnar nerve. That's the ulnar nerve which is compressed between the radial head and the lacertus fibrosus. That's the radial head just underneath the ulnar nerve. So we had to push the radial head back anteriorly and going on to laterally. So that was the easy part, but the trickier part was to maintain it there. So whenever we flex the elbow, unless there is an anterior restraint, this radial head tended to go and dislocate medially in the same place where it was supposed to be there. So at this point, we did the modified belt toss procedure. Forearm fascia was taken, and this was used to reconstruct the annular ligament, and followed up by we took through a range of movements, and the radial head was not dislocating, neither in flexion extension nor in pronation supination. We could achieve near full range of movements there. That's the radial head articulating with the reconstructed annular ligament. That's his immediate post-op X-ray. That's him at 1 year, and his range of movements nearly good. So it's a very rare injury. The anecdotal case reports in the literature, we could get 6 of them. Each of them, the inhibiting force was different. There could be brachialis or capsule, but more often than not, it is the biceps tendon. And in the 2006 article, this is a beautiful diagram which shows what should not be done when there is an elbow dislocation. When there is an elbow dislocation, and when we try to reduce, if the annular ligament is torn, which we will not be able to make out, and we try to reduce it in pronation, the biceps gets displaced medially. Now the pull of the biceps is taking the radial head away from it, so it has been anteromedial dislocation of the radial head. So especially in kids, when there is an elbow dislocation, there are chances they can have an annular ligament tear. We should not reduce the elbow in pronation. It should be in supination or at the most mid-prone. So the take-home message, we need to have a high index of suspicion when we are dealing with an pediatric elbow dislocation that they can have a concomitant annular ligament injury. So always, both in AP and lateral, we check for the radiocapitular line. In whatever view it is, it should be crossing, it should be intersecting. And we need to differentiate between the metatarsic ossification and ulnar ligament ossification, which is seen in this type of an injury. So if there's an ulnar no post elbow trauma, it needs merit, it warrants some things to be done. Thank you very much.
Thank you.
In the interest of time, we'll be stopping here. To conclude this session, simple elbow dislocations usually have a good functional outcome with functional rehabilitation, which is started early. And you should have a high degree of caution and suspicion to check for elbow instability in complex fracture dislocation. Always priority should be to fix coronoid, repair radial head or replace it along with the repair of LUCL. If instability still persists, go on for medial collateral ligament repair, or if instability still persists, then maybe a hinge fixator or an internal joint stabilizer may work. In trans-olecranon elbow dislocation, most important thing is to get the integrity of the sigmoid notch, and of course in children elbow dislocation, always checking continuity of ulnohumeral articulation and radiocapitular line in both views important. Important is to diagnose this injury early, as children may have subtle and mass symptoms. I thank you everyone. I thank you all the panelists and chairmen. Thank you.